Hi, everyone. My name is Sadaf. I'm a consultant neonatologist at Great Ormond Street and UCLH, and I'm part of the NeoFOCUS education team. I'd really like to take this opportunity to welcome everyone to this NeoFOCUS webinar entitled Preterm Cardiac Modeling and an Unappreciated Phenomenon. Before I introduce the speakers and panelists, I just wanted to go over some ground rules. So the chat is disabled, so please post your questions in the Q&A box and they'll be answered in due time. At the end, you will have a link to a feedback form, and once completed, you'll get a link to download a certificate, which you can then self-complete with your name. The feedback link will also be sent to you by email tomorrow. So today, we're really pleased to welcome our speaker, Dr. David Cox. He's a consultant colleague. He's a neonatologist at Great Ormond Street Hospital and the clinical lead for digital child health for the Transformation Directorate at NHS England. He's also an advisor to the Digital Board of Royal College of Paediatrics and Child Health. So he performed his research in neonatal cardiac MRI in the King's College London Department of Perinatal Imaging and Health. He worked with Professor David Edwards and Dr. Alan Groves, and his PhD was in the computational modeling of neonatal cardiac MRI data sets to evaluate preterm cardiac ventricular remodeling. We're also really lucky to have Dr. Neil Patel today, who's a consultant neonatologist at the Royal Hospital for Children, Glasgow, who'll be moderating this session. He's the Vice Chair of the NeoFOCUS Executive Committee. Neil has a special clinical and research interest in neonatal hemodynamic assessment and management, specifically in congenital diaphragmatic hernias. So I'm going to hand over to you, David. Thanks to both of you for being here today. We're really grateful.
Fantastic. Thanks, Sadaf. Can I just get a quick thumbs up if you can hear me okay? Excellent. So the nice thing about working with Sadaf is that I gave her the practical joke of making sure she read out the really, really long bio. So essentially, she says, so I'm a consultant neonatologist who's done a little bit of research. And my talk today is hopefully going to be something slightly different. It's going to lean on a couple of things that I think are really interesting about neonatal medicine and some things which I think may be slightly underappreciated, if not unappreciated, and also has the chance just to talk through a little bit of research, which I did about 7 or 8 years ago now, which I think is kind of really good for food for thought as we kind of venture into the next era of what I think of neonatology, which is looking after the long-term health of our surviving extreme preterms. So, as Sadaf has very kindly introduced, this talk is entitled around preterm cardiac remodeling, and that's kind of what I'm going to go through, because we're going to talk about the fact that obviously we have a huge number of babies now that we treat who are born premature, and the majority of preterm babies are born at the later stages of prematurity. But actually, we know that we're getting better at caring for babies, which means that we've got an increasing cohort of babies who are surviving when born at the extremes of prematurity. How do we look after them and how do we monitor what their cardiovascular status and my own particular interest, their cardiac development is doing? Are we seeing essentially changes in the early stages of neonatal life which might predispose to essentially what looks to be a new cardiomyopathy? It doesn't fit into any of the really traditional boxes. And if this is happening, well, who is it happening to and what can we potentially do about it in the future? And I think there are a huge volume of unanswered questions to do with the latter things, but we'll see how far we get. Okay, so a little bit of context. With permission, these are my two little ones. So these are my twin girls. This was taken a little while ago. They're now applying for secondary school, which is a ridiculously scary stage of anyone's life. So if I've got many more grey hairs, it is because of the love I show for these two and the stress they provide me. But they were born slightly early, as many twins are. And as a parent of a baby born early, or particularly a neonatologist who has babies born early, one thing that you think about is, well, how is that going to affect their development? And many people, I think, understandably focus on their neurological development. Are they going to have outcomes? Are they going to do well at school, making sure they're healthy and grow, etc.? But obviously, with my research interest, I was also quite interested just to see essentially what happens in terms of their cardiovascular status. So what do we know about prematurity? So we know that it accounts roughly for about 10% of global births. And we define prematurity here as being born at less than 37 weeks. We know that the rate of prematurity worldwide is actually increasing. And the number of births therefore accounts to about 15 million preterm births globally per year. We know that the predominance of those babies are born after about 32 to 36 weeks gestational age, so what we'd classify as the moderate to late preterms, about 10% between 28 and 32 weeks, and probably only about 5% less than 28 weeks. But it's probably those which are born less than 28 weeks that we probably worry about the most. We also know that being preterm is a significant cause of morbidity and mortality, and worldwide, preterm birth is still the leading cause of death of those less than 5 years. And if you think about the global burden of prematurity, well, actually, every year a number of preterm babies are born. It's the same number of people that would repopulate Iceland, Finland, Norway, and Denmark together. So if you think about those Scandinavian countries, it's quite the burden of people that potentially could be at risk if we don't look after them properly. So the fetal course of cardiac development is pretty similar to most other organs. And it goes through a phase where essentially the organ is developed, it grows, we get the primitive structures, we know it. But then as we go towards the later stage of prematurity, from about 26 to 40 weeks or so, there's a lot of pruning that goes on. And actually, one of the key things that's been demonstrated is that in fetal life, the heart grows by hyperplasia. So you're gaining more cardiomyocytes. And actually, that's really important. And you can see in this graph, the top graph demonstrates that initially, and particularly as you go through that last trimester, you get an increasing heart cell population, and that's under the influence of a number of different factors. But actually, as you get ready for birth, what also happens to the heart is that you actually get that developmental potential, you get apoptosis and differentiation, which readies that heart ready for the term birth and the kind of change in physiology that's going to happen. Now, one of the key differences here is that actually at birth, you change from a process of cellular hyperplasia or myocyte hyperplasia, making sure that you grow more myocytes, to one of cellular hypertrophy. So actually you lose that proliferative potential, but instead your cardiomyocytes grow and they hypertrophy. And this is a change to how they can action and function. And actually, there have been lots of research studies done before, which says that actually the number of cardiomyocytes that you have at birth is a great indicator of longer-term cardiac health. But actually, with that, we know that a reduced cardiomyocyte endowment has actually got strong links to cardiac health later, ischemic heart disease, but also things like hypertension and everything else, and that might be multifactorial. The other thing that happens in the late stage of cardiac development is you get these 3 key layers. So this is a diffusion tensor image of the heart. So again, it strips away and looks at the orientation of the cardiomyocyte layers and see how they interact. And it's this orientation of these different layers which allows the cardiac function to kind of twist, torsion, and therefore be sufficient as it should be as expelling blood. And if you're born early, the question is whether you lose some of this due to the change of the kind of physiological stress that your heart is under. And I imagine most of the people here are neonatologists, so we don't have to kind of talk through much, but we know that there's a huge physiological adaptation that happens at birth, a huge difference in how your heart has to function, the stress that goes on the right and left ventricles, let alone different things. And what we always talk about is, as neonatologists, we are trained to think about the physiological factors, so the preload, the contractility, the afterload, and the lusitropy. And we know that when we're looking after babies, we're inherently in tune to think about the balance of pressures and flows and thinking about the different things may affect our cardiovascular function. So if you're born early, if we separate it fairly rudimentary, in a rudimentary fashion into the pump and then the blood vessels, we know that the immature myocardium has reduced contractility, and it has that because of the different developmental features. But we also know that actually your systemic vasculature is primed to work in a different way as well. And if we go into kind of more physiological difference, an underdeveloped, so a preterm heart, has got many, many different ways that it's not primed to function as it needs to cope with that change in the afterload, which happens acutely after someone's born. And there are factors affecting the cardiovascular system, which means that they are less able to cope with changes in preload, in contractility, and in the afterload. So essentially, your preterm heart is not really set up to cope with life after birth, so we think. One of the key things, or one of the things that we know, is actually there is differential or kind of changes in your expression of your adrenergic receptors. So we know that there are adrenergic receptors in the myocardium. We know that there are adrenergic receptors in the peripheries as well. And they have very different actions. If you're born early, then not only do you have less sensitivity of these, but you have less receptors themselves. And again, this is one thing that's been proven and shown. But it's not only about the cardiac structure that is different at prematurity. There are a host of different things that our preterm babies are subjected to, from antenatal corticosteroid use, postnatal corticosteroid use potentially, suboptimal nutrition, stress, physical oxidative, a whole host of things which change their physiology, and then potentially could alter all these different factors, could alter the development of the heart. We also know that we as clinicians have got a huge role to play. So this was an interesting study done quite a while ago now in the USA. And they looked at different units across the USA, and they looked at the use of kind of inotropic supportive vasopressors, as they put it. And you could see actually, despite the fact that actually when they interrogated the data, that there wasn't a lot to explain the differential use, you could see that sometimes there was a tenfold difference in the cardiovascular support in terms of the inotropic or vasopressor use that was used. So again, when we're subjecting our preterm babies to actually factors which might alter their development, a lot of it is on us as well to consider what we're using as the tools we use. So I think that is probably the background. We also know that babies born early, or even term babies, they have adaptation over the first few hours, days, and weeks of life. And we know that if we intervene at the wrong time or the wrong way, well, actually, not only what we'd be doing long-term damage, but actually in the short term, it's not necessary either, because these babies quite often find a way to reestablish their cardiac output and their ejection function without intervention. We know there are several things that go on in the transitional circulation as well. We know that they're predisposed to hypotension, and the question we always have to deal with as neonatologists is, do we intervene, or do we let nature take its course without intervening? And again, people still have differences in opinion on how to do this. This talk is not so much about that. I know it's a hotly debated issue. So what this talk is more dedicated to is then thinking, given that background, so thinking about the fact that if you're born early, you're predisposed potentially to have a number of factors which could affect your cardiac development. Well, what do we know? How do we translate that from theoretical pathophysiology into tangible stuff that we can actually see? What is the effect on cardiac development, and what evidence do we have that actually things do change if you're born early? Okay. This is a really nice summary paper that, again, if I can point people to one paper, that this is a really good one. So this was done by a group based in Oxford, particularly Adam Lewandowski, who's led a lot of this work along with Paul Leeson, about thinking about how we understand kind of sequelae of prematurity on the cardiovascular system. So it's a good one to have a look at. So we know we've talked about the fact that there are different factors at different stages which might affect your cardiac performance and your cardiac growth. We know that there's stuff in the uterine environment. We know that there's the transitional circulation which happens or affects the fetal and early life. We know that as you grow in the infantile stage, then there might be some stuff which can affect it. And actually, there have been really interesting studies coming out from the Oxford group, Lewandowski's group, the fact that protective influence of using maternal breast milk as your nutrition has on your cardiac structure and function when you achieve young adulthood. So it's really interesting that that key intervention, which we all promote, is actually can be really, really protective. But we also know it's the health that we have as an adult. The factors, the kind of, what do they call it? The impacts of kind of factors outside as we grow that can affect cardiac development. So in terms of thinking whether prematurity does have effect on long-term cardiovascular health, where is the evidence to say it's a problem? Well, there are associations with cardiovascular outputs like stroke, atrial fibrillation, and early heart failure. And I'm going to focus most on discussing a little bit about early heart failure. There are associations with early onset hypertension. There's associations with systolic blood pressure particularly. There's increased arterial stiffness, associations with metabolic syndrome, and that's insulin sensitivity, whole body adiposity, and the fact that you get higher lipid levels, particularly in the liver and in your muscles as well. We know from studies, and I think this is some really key evidence for what I'm going to talk about, and the reason why I think this is important, that preterm babies are at increased risk of new onset heart failure. So Hannah Carr, she did a really interesting thing. So she published a paper in 2017. And what that did was it actually looked, so Hannah Carr works at the Karolinska Institute. And in Sweden, they've got a really interesting epidemiological cohort. And they had this cohort from 1987 to 2012, so a 25-year cohort. They looked at all the rates of early onset cardiac failure. And they found that the background rate was about 1 in about 100,000 or so. Doesn't sound like a big deal or so. But what they were noticing in Sweden is that between 1986 and about 2006, they had about a 50% increase in the rate of heart failure picked up in childhood. That was fascinating. So she looked at different factors and did actually a regression study with a Poisson analysis, which found some quite interesting things, which I'll come into a second. But the spoiler alert was that actually if you're born preterm, your risk of early heart failure was significantly increased. There have been other studies as well. So essentially, Crump et al. Looked at preterm birth and they looked at heart failure into longer term adults. And it really correlated what Hannah Carr was finding, in that the risk of heart failure was certainly there and found in multiple studies in multiple different populations. The same group also looked at ischemic heart disease. And not only is it about heart failure, but the risk of ischemic heart disease without heart failure was found to be significantly elevated. And again, that probably ties in with the metabolic syndrome that we talked about previously, as well as vascular changes. And Lewandowski as well, so their group, they looked about heart failure and cardiovascular related morbidity or mortality, and they do find it elevated. So we're seeing multiple different studies, multiple different populations, all saying the same thing. If you're born early, your risk of cardiovascular morbidity is significantly increased. So this is the Hannah Carr study that we talked about earlier. So they looked at the rates of heart failure, and the background rate is low, so about 1 in 100,000 in kind of children and kind of young adults or so. But with that, you almost had a dose-dependent relationship with prematurity, saying that the more preterm you are, there are significantly greater rates. And if you look at the relative incidence rate ratios here, so if you're born in less than 28 weeks, you have a 17 times higher rate of having heart failure in the early stages than you do if you're born at term. And that's quite a significant dose-dependent relationship. Again, so we need to think about what it is that might underpin those. But we also know that those relative statistics mean that if you're born early, not everyone is getting heart failure. So why are some people more predisposed to others, and how can we pick those out? Well, one of the hypotheses is that actually it is not necessarily that if you're born early, you have a systematic and progressive deterioration into heart failure. More that there will be insults that might come along through your life, which actually your preterm heart is less able to cope with. And so the resilience of the cardiac or your heart and your cardiovascular system in general is deteriorating as you have these separate isolated events. And if you have a number of isolated events, then actually that might lead you to earlier heart failure. And things like myocarditis, sometimes typically these babies going on to get viral infections which can affect the cardiovascular system, might impact, might tip people into going into heart failure later on. And so what are the root mechanisms by which actually we think that these children go into heart failure? Why are they predisposed? Well, in preterm babies, we found that essentially in adults, they look to have slightly smaller heart size. They've got less cardiac reserve and probably have an element of both systolic and diastolic dysfunction. And we see that essentially aligned to that, not only is the heart changed, but also your vascular system is altered as well. So you've got decreased vascularity, far more rudimentary kind of vascular trees associated with increased vascular stiffness as well. If we take it down a step as well, if we look at histologically and what's going on in terms of the kind of pathophysiology underlying these things, we said, as we discussed before, that they have a reduced myocyte endowment, they have reduced numbers of cardiomyocytes, which might underpin the fact that they have fairly limited cardiac growth. The other thing that they might get is increased fibrosis within that myocardium, which may limit or stunt cardiac growth. They have DNA damage and increased activation of that renin-angiotensin system as well. And because of that, all these things seem to come together to give them heart failure, a higher risk of ischemic heart disease, and both systemic and pulmonary hypertension. We think, and actually a lot of work has been done in humans in terms of the epidemiological data, but a lot of the histological underpinnings for this come through adult studies. So Bensley et al. Did some interesting work with sheep, and there have been also some really interesting rat data as well. And they've looked at the histology of preterm sheep at term-corrected age. And what they see is essentially what we've described previously. The numbers of cardiomyocytes are far fewer. The cardiomyocytes that are there are far more hypertrophied, but there's a huge infiltrate of fibrotic tissue. So you're almost seeing this interstitial fibrosis going on within the myocardium, which might obviously limit your activities. There was also thought, as I said, between those layers, the key layers, myocyte kind of alignment are disrupted as well. And that'd be one of the reasons why they might get both impaired systolic function and also impaired diastolic function as well. Okay, so if we come then to humans, if we want to see if this is a phenomenon which also translates to humans, particularly if we want to see what we can learn, well, what is the best way of imaging to see if this cardiac remodeling is a way forward? I'm not going to demonstrate my ignorance by discussing echo at length, because I'm sure there are people on this seminar who are very, very well versed in echo and all the functional metrics that come from it. But a really nice summary paper by Kuran in about 2019 or so just looked at the different ways that we can image the heart and actually what those things can provide. And when we were thinking about looking to see whether actually remodeling occurs at a neonatal stage and whether it might be of significance, we thought that one of the key things to do was to be able to assess the cardiac structure as well as we could. Now, we're also looking at dealing with small children. So hence we didn't want to give excessive ionizing radiation, particularly not for a research study. So we settled on cardiac MR, because the ventricular volumetric kind of indices were really good. We could do the whole heart imaging, which is nice. And we can also get some elements of functionality as well. So, around 2012, 2013, there was a raft of data published. And this started off using something really interesting, which is the use of computational cardiac MR atlasing to look at preterms and to see how their heart was developing. One of the first bits of kind of seminal work on this was published in Circulation by Lewandowski et al. And they actually took a group of young adults who were born prematurely. That was the kind of blue group. Preterm young adults is what PTYA stands for. And they actually used cardiac MRI to actually both get volumetric measurements and then look at atlasing to get a more in-depth understanding of what their heart geometry was like. And they noticed that obviously if you just look at ventricular mass volumetric measurements using cardiac MR, then actually there was a clear difference between preterm young adults and actually term-born young adults. And that's the difference between the blue and the green, which you can see is very, very statistically significant when you look at that left ventricular mass. They wondered if it was just an aging phenomena. So do they age prematurely? And so the older, so the red things, is that older adults, so not young adults, but adults who are about a decade older or so, and looking at, is it just the fact that these children have aged prematurely? And it is very different from a natural aging process. So there seems to be something very different going on to babies born prematurely. And actually, when they looked at it, what they could then use is the computational modeling to look at how those heart shapes differed. So again, as our blue is our preterm born young adults. So when they're roughly about 20 to 75 years of age. The green was a cohort born at term, so our term control cohort. And the red was a cohort born at term, but slightly older, looking at the aging phenomenon. And what they noticed with these is actually you could use principal component analysis to see the modes of difference. And we can see that if you're born early, essentially what you had is a much thicker ventricular wall, a slightly shorter ventricle, your apex, which was slightly different, and actually it was a much more spherical kind of blood pool as well. So you had some key and obvious ventricular geometric changes, which probably would affect ventricular function. They also went one step further. So one of the hypotheses is that actually the right ventricle might actually suffer more than the left ventricle. And actually, when we look at some of the functional indices in babies born prematurely, their right ventricular functional indices are actually worse than their left. And what they noticed again, when they looked at the right ventricular mass, is you had almost quite a nice dose-dependent relationship with prematurity. So the earlier you were born, the bigger your right ventricular mass or so. And again, we suspect this is closely indicated or correlated with worsening function and morbidity. And again, those are the stats in the range of the data as well. They went on to look at function. They looked at ejection fraction as well as mass. And actually what they found is that if you're born early, your right ventricular ejection fraction is significantly suboptimal. So what we were saying here is that actually we talked about that term dose dependency. So for each week of your prematurity, your ejection fraction as well as your right ventricular mass was significantly altered. So it is quite interesting. There is probably something inherent just to your gestational age, which is being borne out in your later cardiovascular morphology and potentially also your function. Okay. So the title of the talk was about remodelling, particularly cardiac remodelling. It's quite nice. So this summary paper of remodelling talked about the fact that remodelling can occur because of molecular and cellular events after injury to the myocardium. We know that our preterm babies have got fundamental changes with pressure overload, volume overload, as well as changes in how they age. And actually, what we're seeing from Lewandowski's study is that actually we could see a change in the shape, dimension, and function of the cardiac chambers when these preterm born babies reach young adulthood. And actually, if you're seeing ventricular remodeling, well, actually, we know that regardless of the etiology, the process of remodeling and actually seeing a remodeled ventricle is thought to be a common mechanism for the progression of heart failure. Then we think that there is a clear pathophysiology that goes behind it, which is the adaptation of the cardiomyocytes to the stresses that they lengthen. This initially thins the ventricular wall, and then in adults, certainly, they get dilatation, reshaping, compensatory hypertrophy. This causes loss, but increasing fibrosis. And that's what we were seeing when they did the histology, certainly in different adult animal models of the prematurity. Okay. If we're thinking about geometry for a moment, and I'll gloss over this fairly quickly, we know that one of the key things is that the degree of sphericity, so shorter ventricles, which are more spherical compared to those nice kind of slightly D-shaped left ventricles that we're used to seeing, kind of gives rise to several different things. Dilatation and hemodynamic overload, rates of heart failure, reduced exercise tolerance, mitral regurg, and abnormal ventricular rhythms. All of these things are pretty poor and associated with pathology. So we thought, well, the problem here is that if we wait until adulthood, then it's going to be pretty difficult then to institute some stuff which can reverse the pathology. So is there a way? So the core of my research, which was done between 2012 and 2015, 16 or so, was to think, is there a way that we can identify neonatal cardiac remodeling? Does it occur? And if so, what can we learn about it in order to think about whether we can actually identify something which we can use as a biomarker to facilitate us essentially thinking about how we can screen people in future. And actually, the nice thing was Lewandowski had already shown that we can actually create computational cardiac MR atlases which can give us this data. So the key question was, is this something we can do with newborn babies, or is this something which is technically not feasible? And we came into this on the basis of, from about 2007, 2008 at Imperial, they were starting to pioneer neonatal cardiac MR, which really hadn't been done before. Well, certainly there was neonatal cardiac MR for congenital heart disease, that was evolving, but it hadn't really been done on the preterm population, certainly not for functional hemodynamics in the preterm. So Alan Groves, who was at Imperial at the time, then moved subsequently to King's College, and now is working in the States, was really the person who took this on board and actually did some really, well, in my opinion, amazing work about both optimizing newborn MR, cardiac MR, but also getting out some of the functional stuff. And this was the next stage. This was taking cardiac MR and actually using it to produce atlases so we can learn about cardiac development. So we wanted to test the hypothesis that remodeling occurs in the neonatal period. So we published it. This is nice. This is the paper that we published, and I'm just going to go through what we did. So the first thing is that we set up a study to look at babies, and we thought that if we want to look at cardiac remodeling, we want a cohort born early, and we want to see what their heart looks like at birth, and we want to look at what their heart looks like at term-corrected age, and we want to compare this with some term controls. And so we had some pretty small babies. So at baseline, we studied babies who were born at 24 weeks, scanned within the first week of life. So the smallest baby we had was born at 24 plus 2, scanned at a corrected age of 25 plus 1. And so it was really quite little in terms of their weight and everything else. 710 grams that one. And what we did is that cardiac MR is quite tricky in the preterm population. So tricky because obviously these babies are small. And when you're doing cardiac MR, essentially what you need is a nice big structure, which will increase your signal to noise ratio. So in terms of what you want is something big that you can identify. Quite tricky also in terms of their heart rates are really fast. So when you're trying to capture cardiac MR, the temporal resolution, the faster your heart rate, the more tricky it is. But also we all work on neonatal units, so we know that these babies don't have nice regular heart rates. They can flip around, they can get quite frequent bradycardias. And also when that does that, that throws out your ability then to actually what we call bin the cardiac cycle into different phases. So you can look at different phases between end-systole and diastole. So actually the technical aspect was really tricky, and this was really lucky that we had physicists on board with us to try and help and support. But what that meant was that we were able to get images like this. And I think these are quite nice images of a kind of preterm heart where you can actually see the different ventricles and you can actually outline what is the neonatal blood pool from what is the neonatal myocardium. And that's key when you come on to build atlases. What we did is we then had what we call a short axis stack, which was planned, and that let us see from the base of the heart to the apex. So we could then actually kind of draw around what we call segment the heart. Now, our aim is to build a computational atlas, and there are a number of different stages that go through this. The first bit is in the data preparation. So you get your MR scans, and then you segment them to label essentially what is the right ventricle, what is the left ventricle, in terms of both the blood pool and the myocardium. And that was quite laborious. There was some software out there which could automate that function. It didn't work on our size of babies, and because also you had different artifacts in there you had to work with. So we had to trace around these things by hand. So that's the segmentation process. Once you've done that, then in order to try and build a computational atlas, you then have a process called registration, where it sounds counterintuitive. You use a series of both initially rigid and then non-rigid registration algorithms to try and map and then morph every heart onto each other to try and get everything which goes onto a single template. But that in working out how those individual hearts morph to meet that single template, you understand what's called the deformation fields, so how hearts are different. And within that, you can do principal component analysis on the deformation fields to learn and see how different our hearts are altered, how they are different. So just walking through those stages quickly, we had our MR scan, which we then segmented to green being the myocardium, red being the blood pool. And hopefully this shows we could actually be quite accurate with this because the quality of our MR scans. By just doing that segmentation alone, we were able to get volumetric understanding of these different cohorts. And actually one thing that was quite nice to see is that a bit like Lewandowski has shown, based on the degree of prematurity, you have altered left ventricular mass, altered kind of blood pool volumes as well. And again, there seemed to be this nice relationship. The more preterm you were, the bigger both your left and right ventricular masses, and although your kind of blood pools are not as altered so much. We then needed to go on to do the registration. This was quite an interesting challenge. I won't bore you with the details because it was working out an algorithm which meant that we could register things, which means that the data we got out about how different they were could be as accurate as possible. And we used something called a dice coefficient to make sure the algorithm we were using meant that we were going to be as close as we could to essentially what was truly going on. How were these hearts different and how could we prove that they were? The first thing was getting it right. Okay. So what did it look like? So essentially, this is what our registration looked like. The nice thing is that the first glance, you can't see that there is grey underlying these images. You can only see the green stepwise function. And the green stepwise function is essentially how we're mapping any heart onto the template. And the grey behind it is actually the template used. So the fact that you can hardly see the grey template means that actually we're able to map any heart on really quite robustly. But obviously a heart doesn't work in stepwise fashion. So we then needed to interpolate the data to make sure that we could get what we thought was a smooth myocardial contour, which was really critical for then creating those ventricular geometries. And that's what we did. Okay. So what could we create? So this diagram essentially says the top row is what in utero growth looks like. And the red coloration depends on that, gives us the wall thickness of the myocardium. So we could build geometries from 29 weeks onwards, which essentially look to see what their heart geometry was like when we scanned it in the first week of life. So this is what progressive, the top line shows what progressive in utero growth we think looks like. And the bottom row is essentially these were the scans of the hearts when they came back at term. And you can see they look very different from that term control. So the red indicates that their wall is significantly thicker in different aspects. And you can see the one at less than 26 weeks is almost bulbous at the top end as well. So they've got very different geometry. Now, acknowledging these are small data sets, but it's quite significant nevertheless. We did both the left ventricle and we did the right ventricle as well. So we were seeing a little bit of wall change. It was a little bit more difficult to interpret. I'll come on to some of the right ventricular findings a little bit later, which I think are of interest. What we did then, a bit like Lewandowski's group did, is we then did shape analysis. So again, we did principal component analysis on the shape. And one thing that we found is that, the shape of the ventricles were very different. And for the left ventricle, the two main modes that we found of difference through the principal component analysis is that how the apex or how it tapers to the apex of the heart, but also the degree of left ventricular sphericity, which we know from previous kind of studies was associated with morbidity and mortality. And actually the group in blue is all the preterm hearts scanned at term corrected age, and the group in red with term controls. And you can see they're very different groups. Even at term corrected age, we see a clear and statistically significant difference between those hearts of babies born early and those hearts of babies born at when they were due to our term controls. And even though babies were born slightly early, we're still seeing a trend, even at the babies born 34, 35 weeks, towards the hearts looking different. It was less easy to pick out the kind of changes for the right ventricle, but we do suspect that there are also some technical difficulties because of how thin-walled that right ventricle is and the altered shape about making sure that our computational atlases were as good as they could be. So we focus on the left ventricle for the next bit. So this slightly bawdy figure here does, again, three things. So this is looking at growth. So this is looking at the change in the myocardial thickness. And yellow indicates very little change, and the green discoloration indicates more significant change. The top line shows the areas of myocardial growth as you go through gestation. So compared to if you're born early, if you stay in utero, which bits grow normally? And you could actually see that the predominance of growth as you stay inside is actually growth of your septal wall. The middle row shows the differences in growth between, or which aspects of the heart grew differently between babies born early and when they were scanned again at term corrected age. And so you can see here the growth pattern is very different. So you get far more, particularly in the more preterm babies, they don't have that altered differential growth, particularly that septal wall. They have gross growth all over the myocardium. And actually it does get less as gestation goes, but you can see again, even as gestation goes through, it's not in that nice, it's not in the same pattern we see for in utero growth. And the bottom row looks at babies born early scanned at term and their term controls, i.e. this tells you compared to term controls, where is the difference that we're seeing? Which bits of the heart may well have been remodeled adversely, are bigger, thicker, which may later give functional impairment. And you can see these bits, they correlate mainly around the LV free wall. So the LV free wall in our babies born particularly early, they may be particularly affected. So what were the associations? Now, again, I always take this graph with a pinch of caution just because of the low numbers. We didn't actually see a sex difference in how your heart growth changes. If you were born small, I thought there would be a significant difference there. And actually, I wonder if actually being born IUGR gives your heart a little bit of priming. So I wonder whether actually the results are slightly less. There's also obviously a very different kind of profile of your surrounding kind of hormonal environment if you're born IUGR. And I don't think we had enough numbers for the PDA to actually differentiate it, because one thing I thought was that PDA would clearly flag up as a significant factor LV remodeling. But what we did see is that the need for invasive respiratory support, doses of antenatal steroids, and also obviously that degree of prematurity, they had huge impacts on essentially the left ventricular remodeling we were seeing and where those changes were. So coming to the end of it now. So what did we think the conclusions of this were? So our work, I think, demonstrated that preterm birth caused changes to the left ventricular mass, and we could see those, we can demonstrate what they were, and they included changes to the overall mass, the wall thickness, but also the endosylate volumes. We also saw changes in geometry which actually tallied with later heart failure and actually were not inconsistent. They were pretty consistent with what had been shown by Lewandowski and al. When they did the cardiac MR atlases just of in adulthood. We know from different studies that the left ventricular mass was significantly increased. We know this is an independent risk factor for cardiovascular morbidity and mortality. We know that obviously if the changes we observed persist into adulthood, then that would give a huge, significantly elevated risk of cardiovascular events. We know that the geometry is different as well. So the geometry in the left ventricular sphericity we saw, again, that changes not only the function, but is also associated with earlier heart failure. So almost this was a kind of finding for us, which is a real highlight of, oh, there might be something here which we could monitor and use as a biomarker for thinking about which babies might warrant closer follow-up. So we know that obviously sustained high afterload has changes. We think this probably gives rise to myocardial hypertrophy, so myocyte hypertrophy, particularly with gross myocardial hypertrophy, and probably hypertrophic remodeling. We know that there are other facts from literature which might also change ventricular remodeling. Important to be or acknowledge that we can or we didn't research and kind of look into every single factor with these things. The changes in the RV was thought to be less significant, but normally after birth, that RV actually kind of reduces in size, and the RV wall is thought to kind of regress in size as well. And we still saw an increase in size. So maybe that is significant. Maybe they have a lack of reduction in size, and that might be really appropriate or inappropriate. Okay. So coming to the crux of it, we think that we saw that in the preterm, in the neonatal phase, we saw evidence of preterm early ventricular remodeling. And so because of this, it might be that this neonatal phase might provide a potential diagnostic and future therapeutic window. What can we do about it? The honest answer is I don't know. I could speculate that there may well be pharmacotherapeutics that we can use. I'd be fascinated to see the impact of levosimendan, because a lot of the stuff that we see in preterm hearts is that actually the calcium-related mechanisms are not there. So whether something like that, which is a calcium sensitizing agent, could have an effect, that'd be really interesting. But obviously we need more studies to think about whether this is good and whether we should use kind of cardiac MR just as a biomarker to think about remodeling. Is there a role for screening here? So this has been postulated in terms of should all adults born preterm be counselled, firstly, or the parents counselled about lifestyle advice to make sure they know about good cardiovascular health, how to maintain that. Clearly, we should all be doing that. Or whether actually for a group of particular infants should target screening with a number of things, just looking at the different factors, both looking to see whether there are biomarkers, whether we should look and see whether there are any functional impacts of babies at this stage. I don't think I don't know of any places in the UK yet which are actually doing targeted cardiac screening for extreme preterms, just to see how they can support people later. That's it for me. Any questions or comments?
Thanks very much, David, for a fantastic presentation. Really enjoyed your introduction and background, and then hearing about fantastic research and potential implications there. We'll open this to all the colleagues on the call for their questions. So please put your questions in the Q&A, and we'll try and put those to David. We have one question to start with from Umaima, and her question is: the nutritional profile for babies born extremely preterm or term corrected is observed to be poor, and she notes how creatinine can be, sorry, something changed there in my screen. Creatinine is often low in these babies, an indication of their nutritional deficiency. Is there any correlation between generalized poor skeletal muscle mass, creatinine levels, and cardiac development that might be clinically useful?
So correlation between skeletal and cardiac muscle, I'm not sure about, if I'm honest. Again, there is a raft of new studies correlating these things. And again, it's something for me, and obviously whoever posed that question, just have a look at, because it's always right for further research, just to see if we can find these correlations. Because again, it would be lovely if we could have creatinine as a simple biomarker, something we all test, just to correlate for that. That would be fascinating to see how that works. I think the person who posed the question is completely right in talking about nutrition, though. I think nutrition is a huge factor in cardiovascular disease, both early on and later on as well. I touched upon the study from Lewandowski et al. They actually looked at subgroup analysis of the children, so the preterm born young adults, and looked at those who were actually breastfed. And actually, breastfeeding has a hugely protective influence. So it's not just the nutrition overall, but the type of nutrition you get, I think, is absolutely key. And I think sometimes we probably underplay that. The value of breastfeeding we all know to be important, but it really truly is important for so much long-term health.
Great, thanks very much. We've got another question from Justinas. Is there a protocol that you're aware of for preterm cardiac MRI screening that's not in a research setting, that's in a clinical setting? And at what corrected gestational age do you think that would be most valuable?
So again, really good question. So no, I don't know of any protocols. I think so. One of the difficulties is that it's only really now that we're starting to kind of get and appreciate the evidence of what it might mean for long-term health, but still the rates are low. If you think about the kind of hallmarks of any useful screening study as well, is that it needs to be a significant risk. So the risk of disease needs to be significant. You need to have a reliable way of detecting it. That needs to be cost effective. And crucially, you need to be able to do something about it. And the difficulty would be, okay, so if you detect it, well, what does that mean? What can you actually do? Now, you can talk about the stuff that we see used post-heart attack to try and reduce remodeling, such as ACE inhibitors and beta blockers, but there's no evidence that that might work for preterm cardiac remodeling anyway. So is the question of, I think it'd be a really useful epidemiological study, and no, I don't know of any screening things that go on, particularly not in the UK. But again, if you're going to use screening, then you need to have something that you can do about it. And I'd almost pull that back and kind of say, is it that we need more research to see, well, what factors, what agents could we or should we be using which might mitigate this at an early stage?
Thanks, David. I might just add a question of my own following that one. You showed us the huge amount of work that went into the processing and analysis of those MR images to get the data that you were able to present to us. To what extent is that possible in the context of a clinical setting to perform MRI and then perform that level of analysis? And then I suppose the secondary question is, in the years that have passed, because technology changes very quickly, has that become easier? And is there a level of automation that has enabled the kind of user time on it to come down as well?
Yeah, so I'll answer the last question first, if that's okay. So yeah, the software has advanced. It's still predominantly used for segmentation of congenital cardiac lesions, but it is good. It's like anything, the really small babies it's really tough on. And that's both because actually deriving clean images is so much more tricky. So as soon as you get to 3, 4, 5 kilos or so, then the software is pretty good. Still needs a manual kind of clipping just to make sure it's absolutely right, but it is much better. The preterm ones, particularly at early stages, if you're going to scan them early, and again, you could debate whether that's useful anymore, then it is much more difficult, and that's where you still need the manual. The question I think is that I don't think it's feasible to do computational MR as a gross screening tool. But I think what we should be doing is thinking about there are bedside modalities like echo, ECGs, other potential biomarkers that we could get from other laboratory tests, which could be really useful. So how does the potentially computational MR, how does that help support biomarker generation? What is it that we can learn which really correlates strongly with that computational MR? So we don't have to do the MR scans on everyone, but we could potentially do an echo. We could do a blood test. We could do something else. And then we can use that as a marker of these people who are at greatest risk. And we can also use those biomarkers, which would be far more available, to then target studies when we're looking at obviously different therapies which might work. And again, I'm really interested in the MR echo kind of correlation, just to see how we can do that.
Great, thanks again, David. More questions coming in, and please keep them coming. So Marilena asks, what do you tell parents about these concerns?
Okay, this is where I put my honest neonatal hat on. I specifically don't think I counsel these parents nearly as fully as I should, because again, it almost comes down to the screening question as well. So what information are you going to give which is reliable, and what are you going to say that they can do about it? We counsel, I think, and I counsel every parent of a preterm baby, the fact that their prematurity can affect all your organ systems, that actually we know from epidemiological data that there is a lot of stuff which affect different organs, and so a healthy lifestyle is absolutely what we should do. I always counsel about the benefits of breastfeeding. I think that's absolutely key here. But the honest answer is, I don't think we've got enough data to target people and kind of say, if you said to a parent, okay, well, we've got some increased data, but the risk of your baby born at 28 weeks gestation of having heart failure in infancy goes from 1 in 100,000 to 17 in 100,000. What does that mean in reality? So I still think it is just going to be general advice at the moment, just until we can get something, until we've got a more targeted screening program. I think it's limited on the kind of usefulness of those conversations.
Thanks. And question from Anne-Marie. Does the use of postnatal steroids worry you, given the antenatal impact? And how do we balance that against the increased risk of adverse cardiac remodeling associated with ventilation? So I suppose taking steroids and the ventilation there.
Yeah, I think it's difficult. So clearly, in an ideal world, we'd have babies non-invasively ventilated, not requiring postnatal steroids. Everyone is happy. It's the balance of different things, isn't it? So again, I don't think we know enough yet to say the true impact of postnatal steroids. I think it probably does have an effect on your ventricular growth, your cardiac function, and your long-term ventricular remodeling. But again, Anne-Marie's absolutely right to talk about the fact that, well, if you're stuck on a ventilator, well, actually that's going to have a significant effect as well. And I think the thing is that we don't know about the long term, but we do know about the short term. And we know that in the short term, the longer the babies are on a ventilator, that affects lots of different organ systems, neurodevelopment, lung health, cardiovascular function. So I think in this, the lesser of two evils is to try and get them off the ventilator. and judicious use of postnatal steroids is probably a good thing in our armory to support that.
Great. Another question from Mark. He says, many thanks for the excellent talk. Automated computational MR in such small hearts is very difficult, as you said, requiring a more substantial supervision element than with manual segmentation. Are there any external cohort groups looking at validating these findings with different operators performing manual segmentation? I know that Mark's got expertise in this area, so maybe why he's got a technical question for you.
Sounds like Mark is keen to take up the baton and run with it. So go for it, Mark. Now, I think the honest answer is that cardiac MR is really challenging in terms of when it was pioneered by the Imperial Group, which then went over to King's in the kind of early 2000s to the mid kind of 2010s or so, whatever that decade is technically talking forward. I think we were the only group doing it. Now, I think it is of interest. I think the research findings, yes, I'm biased, are of interest, but I don't know of any group that has kind of continued that work. The Vogue very much went on to using computational cardiac MR atlasing for a kind of real and ready way to look at congenital heart disease, how we model that, how we start to plan surgical improvements for those with congenital heart disease. I think it is ripe for further research. If Mark wants to take up that research pattern, I would suggest that would be a really, really good thing to do.
Thanks, David. I know Mark, as I said, I know that Mark has done a lot of his own research, particularly on the right ventricle as well. So I imagine you two have a lot to talk about together. And mine was just I think reiterating feeling from all of us, which is this was a fantastic presentation. Really, thank you very much. I don't know if there's any final questions from the audience. If not, I just had a broader question for you, David, which is taking a step back, and particularly the data that you showed us around the relationship between prematurity and potential for adult heart failure and adult cardiovascular morbidity. How do you think that we as a neonatal group can start to emphasize how assessment and intervention, either prenatally or in the immediate postnatal period, is actually at the heart of solving a lot of the problems that our health services and NHS, I'm thinking of those of us who work in the UK particularly, are facing? That's a different question. It's more of a socio-political one, perhaps, but I'm interested with your broader roles, how you think we do that.
I think it's really interesting. So the science of our specialty has moved on, continues to move on. We obviously had that BAP and framework for practice about what we do about even more extreme preterms around the 22-weekers. And certainly I think all of us will have seen babies who have been born at the extremes of preterm go through the most horrific kind of neonatal journey and yet live to survive the other side. And it's really difficult for parents to make kind of big swathes around public health and prevention and do things because we know that babies are going to be born sick, and that's life. The early prevention, I think, is going to be key. So if we can find stuff which we can see in the neonatal period, in the childhood period, which leads to long-term better health, I think that there are significant cost implications which will help the health service as well. With some of my own other kind of hats on, one thing I think is going to be really interesting is that obviously neonatal critical care, potentially in the next few years, will stop being such a centrally commissioned service and go towards ICBs to fund. And obviously ICSs are there to think about how to kind of prevent, it really is a preventative strategy of health, which kind of drives the long-term health agenda and potentially resource implications as well. So potentially it might be that you get some ICBs think about different screening services for extreme preterm populations just to prevent longer term things. I don't think there's been the health economics done yet to see if that is a viable thing to do in terms of the kind of cost implications of the front kind of loading of the outlay and doing the testing, the follow-up and everything else compared to the reduction in cost for long-term morbidity, but it'd be fascinating. But the general point is that I think as a neonatal service now, we do need to integrate far more into paediatric services, tell them what we're worried about, make sure the data is there that they can see what's happened in the neonatal period. And if well, that means they potentially can structure early kind of follow-up in a better, more coordinated way.
Great. Really interested in your thoughts on that. Thanks, David. And I think it's as you say, with reorganization of services, there's an importance of groups like this one, I suppose, in being collective and raising the profile for these potential preventative opportunities. It's going to be maybe a more important role for neonatologists in adult health in the future as well. Thanks for that. So I just want to thank you very much again, David, for fantastic, honestly, fantastic presentation and really thought-provoking. I know there's some similarly appreciative comments from colleagues in the Q&A as well. I personally just really enjoyed hearing that and could talk about it for another whole hour with you, I'm sure. But we appreciate you speaking to us, especially after, I think, an on-call as well in the end of a busy week. Thank you.
Thank you. It's a pleasure. Thank you.
Thank you very much to both of you. There will be a feedback link that's going to pop up on your screens as soon as we exit the meeting. Thank you. Have a good weekend, everybody. Bye.